everybody.
Yeah.
Welcome to class once again, and we want to do a quick review of the respiratory system. Right now, from our discussion in the past classes, we said that we can divide the disorders of the respiratory system into the upper respiratory and the lower respiratory disorders. For the upper respiratory problems, we have things like cold, catarrh, cough, rhinitis, sinusitis. And for the lower respiratory, we will focus more on asthma and COPD. Right? Now, what is the pathophysiology? How do you describe asthma? We say that in asthma, you see the wheezing sound, like there's always wheezing, there's difficulty in breathing, right? There's also what is shortness of breath. There is bronchoconstriction of bronchospasm, bronchospasm that accompanies bronchoconstriction. Then there's always inflammation that will come with exudates along the respiratory tract. So, having said that, COPD is not too far, but we know that COPD is a chronic condition that is progressive. So, there is a progressive deterioration of the issues there, and they can be well managed. Now, coming quickly to medications, which is our main area here, we discussed that most of the drugs we can give for asthma and COPD can be classified as either relievers or preventers. Most of them will be classed generally as a bronchodilator or an anti-inflammatory agent. Why do we need a bronchodilator? Because one of the things that happen in the cascade of events in an asthmatic patient and asthmatic attack is that like, there is bronchoconstriction. So you want to give a bronchodilator to quickly bring relief, to stop the patient from dying from the lack of oxygen. So you want to give a bronchodilator to stop to reverse bronchospasm and bring about bronchodilation. Then maybe for long-term management of asthma or COPD, you likely will give a preventer, which is what an anti-inflammatory drug, because we know that what is happening here is like there's an inflammatory response or inflammatory response, which is a form of immune system immunological reaction. So looking at our bronchodilators, we have our bronchodilators, they can be classified as the first group here are called the adrenergic agents. Adrenergic agents are agonists here. So we have the adrenergic beta 2 receptor agents. Then we have the cholinergic or muscarinic agents. Then we have the third group, which are the methylxanthines. Looking at the first group, which are the adrenergic agents, we have a acronym called that we have a SABAS, SABAS, that stands for what? Short acting beta 2 agonist. Short acting beta 2 agonist. So the drugs here have a short or a quick onset of action, usually between anything from 5 to 30 minutes. And the duration of action is also short, like 3 to 4 hours at the most. So we have just like albuterol and salbutamol. So this is a drug you will give in an emergency attack, asthmatic attack, because you will see the effect within anything from 5 minutes up, begin to see the effect, and the effect can last for like 30 minutes to like 4 hours. That's why they're called short-acting beta-2 adrenergic agonists. So we have this albuterol, we have this salbutamol. Then we have the long-acting beta-2 adrenergic agonists too. From the word long-acting, meaning that you have the onset of action is probably will not be 5 minutes, will be maybe after some hours, maybe 1 hour or about 1 hour before you begin to see effect. Then the effects can last for up to 8 to 10 hours. So these are the long-actings. So an example is the salmeterol or the ethometerol. So you will not want to give this drug in an asthma attack that you need a quick response of between 5 and 10 minutes, but they also use a method of asthma too. So we have the SABAS and the LABAS here. Then we have the cholinergic antagonists here, which are the SAMAS, which is the short-acting muscarinic antagonist. Then the LAMAS will be the long-acting muscarinic antagonist. So for the SAMAS, we have the ipratropium there. Ipratropium there, which is short-acting, similar to the SABAS. The onset of action is short. The duration of action is also very, very short. Compared to the long-acting, which is like the onset will be longer than the short, and the duration of action will also be longer than the short. Then, or usually, we usually add a SAMA or a LAMA to a COPD case. We have at times there is an overlap between asthma and COPD in patients. So once it is suspected or confirmed that the patient has maybe asthma, COPD, or a respiratory disorder as COPD, usually a SAMA or a LAMA is added to the therapy in those cases. So we have that, and what are the drugs you find from your Ventolin, right? Some of us know Ventolin. Then we also know this other one. What's the other one? Atrovent. Atrovent. So they contain some of these drugs. So the other major bronchodilator we have are called methylxanthines. Methylxanthines would include aminophylines and theophylines. They are also used in the treatment of to they are also used to bring about bronchodilation. How did they act? They act by inhibiting the phosphodiesterase enzyme, the PDEs. They act by inhibiting those enzymes. Once they inhibit it, they bring about there is always an increase in cyclic AMP levels. They break down ATPs. So we have bronchodilation coming in from there. So these are the major bronchodilators that are used in the treatment of maybe asthma or COPD, and they are called what? They are called relievers. They are given during those exacerbations. Then we have the class of drugs that are called preventers. So these drugs can prevent an attack or can reduce the frequency or the intensity of an attack. So we call them anti-inflammatory agents. Now, for the anti-inflammatory, we have a lot of them, but one that's most likely used are the corticosteroids. Now, since the problem we are dealing with is limited majorly to the respiratory system, usually we give what we call the ICS, which are what the inhaled corticosteroids. So we give it through what inhalational route or intranasal route. We try not to give it via the systemic route because we want to avoid systemic side effects. So that's why we say ICS, inhaled corticosteroids. So what you usually find in those are you find the beclometasone, fluticasone. Those ones are the drugs you find as what ICS, inhaled corticosteroid. You will not find hydrocortisone or prednisolone given as ICS because they don't give them via those route of administration, but we give them. So what do they do? These agents are anti-inflammatory in nature. They want to prevent inflammation. So we need to have inflammation, to have bronchoconstriction, to have bronchospasm, to have the wheezing, to have all the symptoms we see in asthma. So by giving an anti-inflammatory agent, we can stop this reaction from starting or even reducing the frequency of that. So that's why we call them preventers. Then we also said that for the times you have to give a patient an ICS, it is important to ensure that the drug is given before the patient brush their teeth or you have the patient rinse out their mouth after intake because ICS, the drug tends to be deposited at the back of the mouth there, where they can easily cause what we call oropharyngeal candidiasis when they get deposited. So you want to make sure that they don't get deposited then. Patients are also taught proper inhaler techniques, either for the NDIs, metered dose inhalers, or for the DPI, dry powder inhalers. So the other drugs are given as corticosteroids are the prednisolone or hydrocortisone that will be given as either tablets, oral forms, or injectables. You will only give this in a serious case of asthma or COPD, where the patient will normally be admitted in the hospital where they can monitor. But generally, you will not want to give a patient that has maybe a mild asthma an inhaled an oral corticosteroid because they will not need it. You only want to give it to a patient that the ICS no longer works effectively in them. So that's when you want to give it. Then we also have another group here called the leukotriene receptor antagonists because leukotriene are one of those are part of those compounds of blood vessel that are complicit or in inflammation. So by giving montelukast and zafilukast, which prevents the binding of leukotriene to the receptor, the antagonist, so we can reduce the intensity of inflammation that occur. The third group here are also is a drug called xylitine. Xylitine is a 5-lipoxygenase inhibitor. Also, is classed under leukotriene receptor antagonist, but specifically it inhibits this enzyme 5-lipoxygenase to reduce inflammation. The other drugs that we have that are not so quite used are the monoclonal antibodies that will include omalizumab, and the fifth one here, the sodium chromoglycate. These are major groups of drugs used in the treatment of lower respiratory tract disorders, usually the asthma and COPDs. So what we say that any of those drugs, because what we have there is a form of inflammatory response, or a form of allergic response. Not all asthmatic attacks are a function of an allergy, but mostly we have inflammation. So we are going to give an anti-inflammatory drug like the corticosteroid to prevent inflammation. So those class of drugs or any drugs that are common are called preventers because you need to give them before the onset of that attack to prevent the attack or to reduce the intensity of the attack. But once you have the attack, like somebody has an asthmatic attack, you not the first line drug you'll be given will be a bronchodilator because you want to ensure that the patient do not die before they get to the hospital or before you get proper medications to them. So you are giving them a bronchodilator because you want to ensure that the bronchioles do not contract again, they relax and these persons can breathe. In worst cases, this person are placed on what oxygen. And I think it's oxygen. I think they give them shot of adrenaline to ensure that they don't die of is it asphyxiation now. Now moving on to some of these problems that has to do with upper respiratory disorders. So either cough, cold, catarrh, rhinitis, sinusitis. Now, rhinitis will be what? Itchy, watery eye and nose that you keep on having water coming out from the eye and nose and it's itching and all that. So it can be allergic rhinitis. Some other cases can be what we call the rhinitis induced by medication. So rhinitis medicamentosa. Now, so for some of those drugs, you want to give possibly a nasal decongestant, which are the phenylephrine, pseudoephedrine, or oxybenzolone. This drug acts on the alpha-1 adrenergic receptor by causing vasoconstriction. What they do is they reduce the circumference or diameter of those blood vessels to ensure that they reduce the congestion and the fluid coming out of the eye and the mouth and the eyes and the nose. Now we have expectorants like e.g. guanfacine is an expectorant that is given to help persons that probably have issues expelling phlegm or thickened liquid in the respiratory tract. So we give guanfacine, we give guanfacine as an expectorant to help them remove some of those thick phlegms. Then we have mucolytic agent to N-acetylcysteine. So what do? They lyse or they dissolve thick phlegm, right? They dissolve so that once they are dissolved, then they can be expelled using expulsion. So mucolytic just want to dissolve those things that clog the respiratory passageways. This one dissolves it, this one helps to expel it. Then we have another decongestant to reduce watery eye, watery nose, and all the fluids coming out. Then some of these cough syrup will come with antihistamines. Why do we give antihistamines? Usually the older generation like chlorpheniramine, diphenhydramine, they are given because we know that for most persons the cough comes late in the night, and once they begin to cough, the coughing would increase into the night. It stops them from sleeping, it keeps them awake, and there's a lot of pain. So by giving antihistamine, this first generation, it does not stop the cough, but it helps the individual to sleep. That's why we add them. Then usually for the cough, management of the cough, sometimes a lot of people are given drugs that contain codeine to help with the relieving cough. Some dextromethorphan, codeine and benzonatate. Now, for persons that have addictive issues or that are addicted to maybe opioid, you want to avoid codeine, dextromethorphan, or codeine because it will worsen their condition. You probably be giving them a drug like benzonatate, which acts peripherally and does not have an addictive tendencies. So, I think with this, we have quickly summarized the major key points under respiratory tract disorders. Thank you.